Okay, good evening, everybody. Can y'all hear me okay with this microphone?
Yes.
Okay, thank you. We're going to go ahead and get started. First of all, everybody should have an agenda packet. So our presentation will follow this order on the agenda. And my name is Claudia Lennhoff, and on behalf of Champaign County Healthcare Consumers, thank y'all so much for being here for this presentation on the so-called One Big Beautiful Bill. We're going to be talking about the impacts on healthcare programs and SNAP and some other stuff. We cannot possibly cover everything, but we will be covering Medicaid, Marketplace, Medicare, SNAP, and some other items along the way. I wanted to, before I introduce you, I just wanted to mention a little bit of housekeeping stuff. First of all, hopefully everybody has a packet. Second of all, hopefully everybody's signed in, especially if you want to receive updates, because as these policies unfold and as more legislation is passed, we will be providing updates over email. And our email list is not a heavy traffic list. We try to be really targeted about what we're sending out. Secondly, if you need to get, bring it up.
Just tap it.
There you go. Sorry. Email list. And then the other thing is also that if you want refreshments, feel free to get up and help yourself. If you need to use the restrooms are out the door and to the right. And then if you have cell phones, can you please make sure that they're on silent or vibrate, please. That reminds me I need to check my own, which I will do in a minute. Is that me?
I don't think so.
It is me. I can't touch this or move this. Okay, I'm sorry. Okay, I wanted to introduce y'all to our brilliant coworker, Babatunde Amao. Babatunde is our resident expert on the law and on legislation, and he read the entire bill, so you don't have to. Sometimes this work is painful. So he did that, and then he did a write-up for the rest of us on staff so that we would have an understanding of what's going on, and we're drawing from his work for the presentation today. And although Babatunde doesn't have a specific, yes he does, I'm sorry, he has a specific section on the agenda about SNAP, it's number 7, but you will see him up here a lot because he might have to jump in and provide a little bit more information on the things that we are discussing. I'll give you a quick example. We're going to be talking about the policy changes and what they mean and how they will affect people, but there are some things that are very in the weeds. We won't really get into them in any big technical conversation or anything like that, but there are certain things where, for example, definitions have been changed. So, for example, there might be a change to the definition of what is a family, okay, that will affect who can get benefits. This was not made public. I never saw that explained anywhere, but Babatunde identified it. So he'll jump in as needed. So I just wanted to explain, if y'all see him just hanging out up here, you'll understand what's going on. Okay. I think that's it for the, oh no, I need to talk about our organization. So just for those of y'all who might not know, Champaign County Healthcare Consumers, thank you. Champaign County Healthcare Consumers, we're a grassroots consumer health advocacy organization, and we've been working for healthcare justice since 1977. So in 2027, it'll be our 50-year anniversary, and we'll be doing events around that. We're a very unusual organization because we do both direct services to help people. Our services are free, but we also do advocacy and community organizing, and we marry those two things together because when you're doing the direct services, a lot of times you'll see where the system kind of falls apart, or where there are gaps in the system that should be serving people, and that can be at the institutional level, like at a local hospital or something. It can be county-wide, it can be statewide, or it can be federal. But that's why we do both. Our client service work informs our advocacy and community organizing work. We are a 501c3 nonprofit organization. We are a nonpartisan organization. We advocate based on policy and not politics. But it is really important for people to understand that the bill that we are talking about that passed, the budget bill that was signed into law on July 4th, is not a bipartisan bill at all. It was all passed through Republican votes in the House and the Senate, and then of course the presidency. And the reason that I mention that is just because so people understand, you know, if you're upset about some of the stuff that you learn, and you want to make a difference, one of the most important things is to be registered to vote, to be an informed voter, and to vote based on, you know, that information, including policy, you know, pledges and things like that. So that is all I wanted to mention. And I'm going to invite my coworker, Chris Garcia, up here, and he is going to talk to you about the overview of the current healthcare landscape. This is before this budget bill touches these programs, and we're doing this as foundational, just so people understand how we're deviating from what we currently have. All right, Chris.
Hi everyone, so like Claudia said, we're going to go over the current overview of kind of healthcare and the landscape and what it looks like right now. So the Affordable Care Act was signed into law in 2010. Its goals were to expand access to affordable health insurance and improve health insurance itself. So before the ACA, people were essentially living sicker, dying younger from preventable diseases. At the time that it was signed, we had over 50 million uninsured Americans. So one of the big changes that you might remember, just because it's a very popular one, was the pre-existing conditions. So that was no longer considered a factor when determining eligibility. One of the other ones that we got listed here is adults under the age of 26 were able to stay on their parents' insurance. It expanded Medicaid, so that's for the adults between the ages of 19 and 64. In Illinois, that's roughly about 770,000 adults. The main criteria was that they met the income guidelines, which was about 138% of the federal poverty level. One of the big parts that we're going to talk a little bit about as well is going to be the marketplace, or healthcare.gov. We created the marketplace so folks that were above that 138 would be able to shop for insurance independently. And then in addition to that, the big key part that really made it affordable was the tax credits or the subsidies. So that was tied directly to your income, and that, you know, determined what your out-of-pocket cost was going to be for your premiums. You know, there were also additional things like cost sharing reductions, and then one key part was that it's actually created protection across the board. So with the 9% of your annual gross income, if you were paying for insurance at a higher percentage, that was considered unaffordable. So you had the option to opt out and shop on the marketplace and see if you could find something that was better, either priced better or had better co-payments, deductibles, out-of-pocket maximums, things of that sort. Medicaid expansion being the key and critical part of the ACA, because it essentially helps a lot of our most vulnerable population. On the right side here, you're going to see a chart for eligibility based on the federal poverty level. So for children, they have a higher threshold, so 318%, and below, children are still able to stay on Medicaid. That's for the All Kids program. For pregnant women, it's at 213 percentile, and that's for the Moms and Babies program. For parents and childless adults, that's the 138 percentile, and so that would be bulk of our adult expanded medication, or Medicaid, so that 19 to 64 age range. And then we've got seniors and folks with disabilities, so if they're below the 100 percentile of the federal poverty level, they can still get Medicaid, regardless of whether they have Medicare. And there's additional state-run programs like Medicare Savings, and so that really kind of helps to make insurance more affordable for those folks. And then when we look at on the left side, who is actually enrolled in these programs, in Illinois at least, at the end of fiscal year 2024, we had over 3.4 million Illinoisans enrolled in Medicaid. So 44% were children, 9% seniors, and about 7% were adults with disabilities. Other impacts for the Affordable Care Act had, specifically for Medicare beneficiaries, was that it started closing the prescription drug gap. And so that donut hole, as soon as the law came into place, every year it started phasing it out. So then eventually, prescriptions would be more affordable for folks on Medicare. Established free preventative services for all insured. So it had the 10 essential benefits and then preventative care overall. And then the important part to remember that we kind of forget just because we are familiar with it as the ACA is that we forget that there's a patient protection part. So the patient protection part is what expanded it to other insurance. So employer-based coverage or individual coverage that you were shopping for outside of the marketplace. And so, things like just standardizing the benefits, making it more affordable, making it so that insurance companies have to justify changes if they were going to raise the prices or change formularies, things of that sort, were really some of the big protections that we had because of the ACA. And so I'm going to pass it back to Claudia to speak about the new bill now.
Thank you, Chris. Okay, so the purpose of that was just to show where we are, where we've been the last few years, and then understand the changes that are coming. I'm going to be talking about the so-called One Big Beautiful Bill Act and what you need to know big picture. And then we'll get into some specifics. First of all, our focus is on policy analysis and the impacts of the policy changes in the budget bill on people and communities. Again, this is not a political discussion, but a policy discussion. And one recommendation that I would have is at every step, as we're reviewing the policy changes, part of the way to think about policy is to think who are the winners and who are the losers. Because it's a budget bill. So it's about money. It's about dollars. And so that's sort of the framework that I kind of use when I'm looking at policy, budget bills, things like that. So the other thing that we use when we think about policy, big picture, is we use the framework provided by the Hippocratic Oath, which is the widely recognized oath of medical ethics taken by physicians, and people are probably familiar with that. It's first, do no harm. And we use that analysis to think about policy. We certainly use that analysis in our past when we were working on medical debt and getting hospitals to have better financial assistance programs instead of suing people and having people end up in jail because they couldn't pay their debt. And that is what happened in this community. We were kind of famous for it. So part of the way that we approached the healthcare systems was to say, first do no harm, and that's not just on the clinical side, that's on the administrative side. So the other thing that we consider, so you'll hear us talk a little bit about some of the downstream effects of some of these policy changes, but the other things that we consider are the public health and the systemic impacts of policy changes. So we'll be really focusing on the impacts on individuals and households, but really we gotta think bigger picture, because if people live sick, if they live without health insurance, they might not go and get health care when they first should be getting health care. And we all know that prevention, early detection, early treatment, saves lives. And that's why all that preventive focus was put into the Affordable Care Act. But we are moving away from that very rapidly. And I'm not even talking about the stuff going on with the CDC and immunizations and repealing, environmental protections that we know make people sick. That's the backdrop of what is happening that is putting people at greater risk. And at the same time that we are putting people at greater risk, we are also, through this bill, taking resources away from people. So those are the things to consider. Okay, so first of all, the budget bill was signed into law on July 4th, 2025. Did it have to be signed into law by then? Did it have to be passed by then? No, it was completely arbitrary. That was a goal that Trump set, and then used that pressure to kind of drive the House and the Senate to get with it and get it done. And a lot of legislators have since, including ones who voted for it, have since admitted, I didn't know that was in there. I didn't know that was in there. So it was really sort of a false sense of urgency, and I would argue that that was done so that it couldn't be examined carefully. And now some people will say, well, that's how the Affordable Care Act was done, because it was passed, at midnight. But that was after months of hearings, congressional hearings. That didn't happen with this bill. So, big picture, what this does is it cuts $1.1 trillion from Medicaid and marketplace health insurance, and it has other major cuts to SNAP, which is food stamps, and various agencies also that provide or help provide community-based health care. There are organizations or agencies like SAMHSA, Substance Abuse Mental Health Services Administration or agency. I don't remember what that last A is for, but they do a lot with funding substance use disorder treatments at local community levels and things like that. They were operating the teen suicide hotline. That was cut. Why? Why do we want teens to not have access to a suicide hotline designed specifically for them? The other thing is that this budget bill increases the national debt by an estimated $3.4 trillion. This is an increase. We already have a deficit, so this is in addition over the next 10 years, and that comes out to over $4 trillion when you start accounting for interest that we owe on the national debt. And that change will also have trickle-down effects, on interest rates and things like that, and how you can borrow money and at what interest rate, and savings accounts and what interest rate you get there. There will be those ripple effects for that. One thing that's important to understand about this budget bill is that it represents the largest reverse transfer of wealth in our nation's history. And what do I mean by that? I mean that the cuts are coming from programs that affect low and middle income people in order to provide massive permanent tax cuts to the wealthiest Americans and corporations. That is a transfer of wealth through policy, through budget policy. Does that mean my time's up? Oh, okay. 3 minutes. Oh, okay, thank you. And, just as an example, so it does this transfer of wealth. It provides these massive permanent tax breaks. And guess what happens when those wealthier entities and people are not paying taxes? We're defunding the government. We're defunding the federal government. Slowly and surely, that is what is happening. So it also increases, spending on other programs, like funding for ICE, right? Immigration enforcement, by threefold to, so that's $29.9 billion, and by $46.6 billion to the border wall. Military spending is also greatly increased. So those are the things that happen. I think when thinking about a budget bill, any budget bill, not just this one, I think it's important to understand it as a moral document. And y'all have probably heard this before, that a budget bill is a moral document. And the reason it is because it expresses a government's values through allocation of resources, reflecting ethical judgments about who and what are most important and how resources should be allocated for the common good. That's us. A budget reveals a nation's priorities by showing which programs, services, and populations are supported or neglected through spending and taxation decisions. So we'll be talking about that today. The last thing in this section, I think, is this it? Oh, sorry. I need to speed it up. But the last thing that I wanted to mention here is also beware of disinformation. Okay, there's ways of packaging information and telling you that, a lot of money is now going to go to rural hospitals, for example. There is a pot of money for rural hospitals, and we'll kind of talk about that later. But that's against the backdrop of rural hospitals losing Medicaid payments as people lose their Medicaid coverage, and rural hospitals will have more and more bad debt. So you have to be really careful how information is presented to understand what it's really doing. And we'll get into this in the presentation, but the Medicaid and SNAP changes include stricter eligibility and additional rules for keeping benefits, plus outright cuts also. So there's a lot more paperwork, administrative paperwork for the beneficiaries that will make it harder for them. Certain states will also be penalized for certain administrative issues and for providing expanded programs. So what that means there is there are certain penalties that we'll talk about that only affect certain states, and primarily they affect states like Illinois, who chose legally under the Affordable Care Act to expand Medicaid. That was a thing that states could do and that many chose to do. The states that became expansion states like Illinois are treated differently in this budget bill than the non-expansion states, okay? So, anyway, I'll hold my comments. So, these cuts have been made under the guise of efficiency and fraud reduction, but there is no evidence to support that these cuts will improve efficiency. They will really only cut benefits, and we'll talk about that later. But also, one thing to remember, the fraud in Medicaid and Medicare, and if there is any in the marketplace, it's not by consumers, it's by providers. That's who can perpetrate massive fraud on these systems, but it's consumers who will be hurt. There will also be impacts on disability benefits. We're not going to get into that tonight, but we will probably have a separate meeting about Social Security and disability benefits, because we can't cover everything. So, wait, so now it's my turn. It's your turn. It's Adani's turn now. Thank y'all. Thanks, Adani.
Hey everybody, my name is Adani Sanchez, and I'm going to go over what changes we are looking for Medicaid. This law is expected to cut Medicaid funding by over $1 trillion over a period of 10 years. What this actually looks like is 10.5 million people losing Medicaid by 2034. And this is going to be done in a couple of different ways that we'll talk about in detail. But this is going to be about work requirements, stricter eligibility, new redeterminations, cuts to expansion states like Illinois, and the exclusion of many immigrant groups. So reducing the amount of people that are actually eligible for benefits, and changing those rules. So right now, Illinois does not have a work requirement for Medicaid. Some other states can put those in, and they're usually imposed on ages 19 to 54. We expect this to be effective in January 1 of 2027. That's kind of when states are expected to put this into place. Note that we do not have implementation rules about this yet. So the state of Illinois, even if they wanted to try to enact this today, they do not have guidelines from the federal government to get this set up. But to be clear, what that means is that they are going to try to make sure that folks in this category between 19 all the way up to 64 have to show proof of 80 hours a month of work, training, or volunteering to be able to keep their coverage. There's no longer going to be an exemption for non-disabled veterans or homeless people. It used to be that if you had children under 18, that was enough to be an exemption for the work requirement in other places. And now the qualifying dependents have been decreased down to 13 years old. So if you have someone in your household who is 13 years old or younger, you can get an exemption from that work requirement because you have smaller children. But it used to be that you could have older kids and still qualify for that exemption.
What does able-bodied mean? I see that.
Exactly. So this is how they're defining, they're defining if you are not actively receiving Social Security disability benefits. That's basically.
So even if, okay.
Right, exactly. So this is a definition that they're coming up that is not going to be based on realities, if you want to talk about that today.
Good evening, everybody. So, answering that question, I also want to urge everybody, if you have questions, you can write them down. We're going to have question and answer section at the end, so that we can move pretty quick because there's a lot for you guys to hear tonight. Able body, according to this bill, anybody that's not medically fragile, if you can walk, even if it's 2 shifts a week, if you can work 2 hours a week, if there's no medical document to back up that you cannot walk, then you're able-bodied.
So, sorry, just a clarifying question. So, one of the things that we do at Healthcare Consumers, we help people apply for disability. It is a long, nasty process, very difficult. So, if somebody is functionally disabled, but they have not yet been deemed disabled by the Social Security Administration, they might not be considered disabled for these purposes.
Yes.
Potentially.
Yes. Or if they are ready to go down the rabbit hole, they would have to go to their medical care provider, and they would need documentations that shows that literally a note from their doctor that says they are not able to walk. Because we've had to go through this process also for people we are applying Social Security disability benefit for, where they are not able to walk. They need a form of proof that they are not able to walk in order to get approved for disability. We'll reach out to their doctors to write a note for them. So if you don't have Social Security disability benefit and you need to get on Medicaid, you might need a note from your doctor saying you can't walk.
Thank you, Babatunde. So current coverage and renewal process, so to add on top of the expectation for work requirements, this is another step where we're adding paperwork, we're adding barriers where it's like, actually, you're gonna have to come back and give us some paperwork and we may or may not accept it, right? Like we're testing out what they'll accept. So usually Medicaid is renewed just once a year. Coverage can be backdated 3 months. If you're new to Medicaid and you are interested in applying, you could backdate your application for 3 months. And right now there are no co-pays associated with Medicaid. What this new budget bill does is it does increase renewals effective 2027, increase renewals to every 6 months. So now people have to renew twice a year. And then in 2027, it also would be cut back. So if you're new to Medicaid, you could only backdate your coverage to 1 month. This is actually going to be a huge impact on healthcare providers. We talked about rural hospitals, but also places here locally like federally qualified health centers that rely on Medicaid being able to pay older bills and kind of get those bills paid so that they can have money to pay their doctors. And so this backdating thing seems like kind of a minor thing, but this is actually a really big deal for providers, smaller providers who are actually serving largely Medicaid populations. So again, this is going to be a loss of funding in our communities, and what we see in other places is that a lot of the time those costs get spread around to other people, possibly people with private health insurance, with higher facility fees, higher insurance premiums, higher costs for some of those things as those costs are passed along. And then effective October of 2028, the states are being asked to charge co-pays as a form of like buy-in from beneficiaries, which is very hard when some of our beneficiaries make no money. So this will be something very difficult and is definitely taking us backwards in terms of that, some of that coverage that we talked about, that we made way with the ACA on some of that coverage. Right now, Medicaid does require some levels of several documented immigration statuses. They do allow them to apply for Medicaid. There are specific programs that do not look at immigration status, and those are state funded. Those are not federal programs, and those are not paid for by the United States government. And those are programs that support children under 19 and pregnant people. So again, when we talk about who are the winners and the losers, the state of Illinois is being punished for providing additional programs to support children and pregnant people. So when we're talking about winners and losers, and there's people are talking about who's getting these benefits and they're not supposed to get these benefits, we're talking about vulnerable populations. We're not actually talking about criminals or any kind of bad people. We're talking about very vulnerable populations. And then so in October of 2026, humanitarian statuses like refugees, which again are considered legal statuses, folks with visas, refugee visas, will no longer be eligible for Medicaid. And I did want to make a note that because the state of Illinois works so hard and pays out of their own state funding to support children, Illinois has an effective 100% insured rate for children. That is unheard of in places like my hometown, like my home state, Texas. They have several children who are suffering because they refuse to expand Medicaid and refuse to cover a variety of children and make it very difficult to apply for Medicaid. And then I will hand it over to Ashley Shaw, my coworker, to talk about what to expect with the marketplace.
Hello everyone, my name is Ashley Shaw and I'm a healthcare navigator with Champaign County Healthcare Consumers. So what to expect when changes to the ACA marketplace? The law will have a deep impact on those who rely on the marketplace, which is healthcare.gov, for affordable coverage. The law allows the expanded premium tax credits to expire, making health insurance plans far more expensive. These changes are expected to increase premiums for millions and cause an estimated 6 million people to drop from ACA marketplace coverage. So the current coverage and renewal process, as of right now, self-attestation is accepted for income when tax data was not available. Enhanced premium tax credits provide additional subsidies on insurance plans. Premium tax credit repayment limits based on the federal property level. And open enrollment is from November 1st to January 15th. So with the OVA coverage and renewal process, the changes effective August 25th, 2025, there will be income verification required. So the previous law allowed consumers to give a verbal or written statement to verify their income. Now a consumer must provide paperwork such as pay stubs, tax returns, employer letters, and unemployment benefit statements. And not everyone has easy access to those documents. People who are self-employed, people who are paid by cash, or just people who have change in hours. The enhanced premium tax credits were more generous. Those come into effective January 1st, 2026. The enhanced premium tax credits will expire. And those people were able to find more affordable coverage with those credits, and those who were already covered through the marketplace their subsidies increased.
Ashley? Yes. Can I just mention something real quick? In case people aren't familiar with that term, enhanced premium tax credits, that was what Ashley's been talking about. That's actually what made the health insurance plan affordable. It reduced people's monthly premiums because they would qualify for a certain amount of premium tax credits based on their income, and that's what made the health insurance in the marketplace affordable. And when the law was created, those were to be renewed, but the budget bill made sure that those were not going to be renewed. And that's why some of y'all might have seen stories from the Chicago Tribune and other places saying Illinois marketplace plans are going to go up by like 200% or more. That's why, in terms of out-of-pocket costs for people. Sorry.
So, yes. So also, effective January 1st, 2026, the premium tax credit repayment limits will all be recouped unless a person's income is below 138% of the federal poverty level. So right now, if a consumer underestimates their income, there is a limit to how much they are required to pay back, and that's usually reconciled at tax time. But with the elimination of repayment limits, it will require a consumer to pay back the entire amount of subsidies that they receive, which could be thousands of dollars for some. Repayments will have a huge impact. I'm sorry, what did you say?
I had a question. How will they be recouped? I mean, are we gonna send more ICE people out?
It's funny because it's sad, but yeah.
So I'll give you an example how they recoup overpayment for SSI or SSDI. This is Social Security Disability Benefits. For SSI, it's a need-based disability. If you get that, it means you can't work. So if you start working, you get a job at McDonald's or Hobby Lobby, and you reach out to Social Security because you are expected to inform them when you start working. And you tell them, cut my benefits, I'm not working, and they keep paying you. They would continue to calculate that against your Social Security number. The payment will continue to accrue on your account, and it will be counted as an overpayment. So if you file taxes and you have tax return, or in the future you qualify for SSI again, they would recoup those. So that is how the government will recoup any form of subsidies that you get and you're not supposed to.
Or it might be through the IRS in this case.
Yeah, so specifically, sorry.
Yeah.
So with ACA, this is already done through the IRS. The tax subsidies, they're called a tax credit because the IRS is giving you a tax credit in advance. And so when you reconcile, when you file your taxes, that tax credit is kind of double checked. And so if you were supposed to get a higher tax credit, you would get an additional tax return. And then if you were supposed to get less of a tax credit to help with your health insurance premium, you would be asked to pay back what you've already received. So this would be an increased tax bill. Like this particular thing, the premium tax credit, would be recouped as a tax bill from the IRS.
So it will all happen through the IRS?
Yeah.
For specific, yes, for the ACA, the premium tax credits, that will be through the IRS.
If you're getting a tax return, they'll take that. If you're not getting a tax return, you'll get a bill or have to set up a payment plan.
Thank you, Adani. So then also effective November 1st, 2026, open enrollment will be from November 1st through December 15th. So the enrollment period has shortened, which will give less time for consumers to enroll and even to correct issues, whether it be.
Do you have to enroll under this one big beautiful bill?
Nope. Nope.
Nobody has.
No, you don't have to. But if you do, you have a shorter time frame now.
Yes. So
Basically, they found a way to get rid of ACA without actually getting rid of ACA.
Yeah, it's ways of chipping away.
Yeah.
Yep.
So the enrollment period has shortened, and sometimes there are issues that need to be corrected, or like verification issues, and people just wouldn't have enough time. and they could possibly fall through the cracks and not get insurance. So current eligibility for DACA recipients, which are deferred action for childhood arrivals. They qualify for premium tax credits if they meet certain IRS requirements. All lawful permanent residents were eligible for coverage and will qualify for premium tax credits if within income thresholds. And then enrollees with income below 150% of the federal poverty level may pay $0 in premiums or benchmark plans, so they could have a premium as low as $0 a month. And then the ACA, bronze, and catastrophic plans were not eligible for HSA, a healthcare savings account. So with the OVA eligibility effective August 25th, 2025, DACA recipients are no longer eligible for any premium tax credits. Lawful permanent residents, which are green card holders or residents with different visa statuses, will not, under 100% of the federal poverty level, will not receive any premium tax credits. The benchmark plan will mean increased premiums for everyone, including very low income households. And the benchmark plan is the second lowest plan for the area. And also, it allows bronze and catastrophic plans to qualify for HSA accounts. And most people who are not able to afford higher tier plans most likely cannot afford to put money aside for catastrophic plans. So here's a chart here with just some rounding. It's for a family of four, and it's showing the possible increases, estimates. So for the first one here, a family that makes $55,000, they fall around the 171% federal poverty level. Their premium could go up $74 a month, around, and then expected out-of-pocket cost increase around $111 a month, and then their out-of-pocket maximum increase could go up anywhere to $300 a month. And then there's ranges. These are price increases that some might be able to afford, but for those not earning as much, could mean not getting any coverage at all. And 4.2 million people would drop coverage in the next 10 years, according to the Center on Budget and Policy Priorities. So HSAs are not a replacement for comprehensive insurance plans. More people will not have subsidies to reduce the cost of the premiums, and this will lead to a greater number of people who will not be able to afford coverage. Enhanced verification of eligibility requirements will delay people's access to care during special enrollments and increase likelihood that they lose coverage. And so 50 billion, so the government will be offering 10 billion per year to rural hospitals that apply to make up for the cuts that they're making to the healthcare system. But the funding does not make up for the cuts to coverage. That means hospitals will have more unpaid care due to people going without health insurance. Thank you.
I just wanted to mention something on that last slide. There was all this fanfare about this $50 billion over 5 years for rural hospitals. This is part of the, it's a real thing, they did budget for that, but this is part of the disinformation effort, because in none of that coverage did they ever talk about that will not make up for the shortfall from people losing their Medicaid and losing their private plans through the marketplace. So that's the kind of stuff, a lot of times it's announced with like great fanfare, like it's a, big deal. And, but like you're not seeing the rest of the story to put it in perspective. Okay, I'm gonna be talking about Medicare. Real quick though, I wanted to mention that there is a green handout in your packet that talks about why, work requirements are bad policy and why they don't work. We're not getting into the weeds on that, but you can read up on that. Now I'm gonna talk about, Medicare and what to expect. And,
And what's the difference? It said both, on a couple of slides back, it said Medicaid, and now it's saying Medicare.
okay. Medicaid is a health insurance program that is a federal and state partnership to provide health care coverage for low-income people. Okay, and somebody can have both Medicare and Medicaid based on their income. Medicare is the health insurance plan that is available to people when they turn 65 years of age and they've been paying into the Social Security Medicare system through their payroll taxes. The other people who can benefit from Medicare are people who have been deemed disabled for SSDI, and who have been approved for that program for 2 years or more, then they're allowed to enroll in Medicare. So people can have both depending on their income. There are low-income Medicare beneficiaries who also have Medicaid to help out. Okay? So the Medicare changes in this bill are more subtle, but they will still be harmful to certain populations, especially low-income Medicare beneficiaries and certain immigrant groups, even though they have paid into the system. It's not fair, right? People have paychecks, they're paying into the system, but they won't be allowed to benefit from it. Low-income subsidies for premiums and co-pays are frozen until 2034. This is Medicare savings. Okay, so how many of y'all are aware of Medicare savings program? Okay, some of y'all know. There's a program called Medicare Savings. It's for lower income Medicare beneficiaries, and it can help pay the Part B monthly premium and other stuff. It basically reduces the out-of-pocket expense for low-income Medicare beneficiaries. Those subsidies are frozen until 2034. So almost 9 years, regardless of increases in the cost of living or anything like that. So what I want you to think about again is who are the winners and who are the losers? Who's losing here and how are they losing? And some of it comes out in the form of just greater expenses all the time while living on a limited fixed income. We love the Medicare Savings Program. We hired a person to help find low-income seniors and help enroll them into that program because it's so helpful. So this is really upsetting. So it'll limit access to these subsidies because the amount budgeted is frozen. So, you know, unless it's by attrition, new people going into Medicare who should qualify might not be able to access this benefit. So these changes will shift costs to low-income Medicare beneficiaries and increase out-of-pocket costs. Because the Medicare monthly premium for Part B right now is $185. How much? $185. Yeah, thank you. $185. So, delays in the Medicare Savings Program reforms, which were supposed to happen. We were supposed to be making that program easier for people to apply for, because trust me when I tell you, none of these programs are easy to apply. That's why we have thousands of clients, because we help with that process. And that goes through the state. And the state is overworked and overburdened, and they make mistakes, and people like us help sort it out and help people through that process. Immigrant eligibility changes, including affecting documented immigrants who have worked and paid into the Medicare system, but who will no longer qualify. So remember also about the public health issues. We're taking health insurance away from immigrants of all kinds of statuses. And, you know, that has impacts on community health and public health whenever anybody loses access to health insurance, because what's health insurance? It's your passport to health care without the worry of the financial cost. The other thing that will be happening is there will be stricter verification of eligibility for coverage. Is this for Medicare coverage?
Things like the Medicare Savings Program, I think, are gonna be additional renewals,
Oh,
additional,
yeah.
like, oh, wait, have you shown us your paperwork about your pay stubs or what you're paying?
Got it, so more paperwork. Those work requirements, I just think of them as paperwork requirements.
Yeah.
Okay? The other thing that's happening, and this is a huge disappointment also, and again, think of winners and losers here as you think of the policy implications of this. Long-term care changes, including repealing the nursing home minimum staffing rule. We passed that. We got that passed. That was a bill that would require a certain minimum staffing at long-term care facilities, because we know that inadequate staffing is not only hard on the staff who work there, but it's also hard on the patients and residents who stay there, and hard on the families and friends who are trying to support them. A bill had actually been passed to increase the staffing levels and to implement it gradually. This was repealed as part of this budget bill. And then, wow, who's the winners and the losers of this? Medicare's ability to negotiate drug prices is gone. That's another thing we were working towards. So what does that mean? Higher costs for prescription drugs. So I think that concludes the Medicare section. I think the thing to remember about the Medicare section is it's overwhelmingly lower income people who will be affected. But then for the rest of the community, it's the same as some of the other issues, that as people are losing benefits and resources, they're paying more out of their pocket, they're struggling more. And then the other thing that's gonna happen is local governments and social service agencies that try to help people, they're gonna be overstrained because of this. And that concludes that section. I will now turn it over to Babatunde for the SNAP section.
All right. Can everybody hear me clearly? So, SNAP is the Supplemental Nutrition Assistance Program, also known as food stamps. We know that, I think this is also the EBT card that we use at stores. The budget bill, as we know, have significant cuts for this program also. So the Congressional Budget Office estimates that SNAP enrollment will be reduced by 2.4 to 4.7 million people per month between 2028 to 2034. And the reason behind this is because there's now more stringent verification requirements, and also there's a huge cost to this program. Illinois, as a state, has one of the highest SNAP enrollment rates in the Midwest, with about 1.9 million residents, roughly 15% of the population receiving food assistance as of April 2025. Currently, where things stand right now is that Illinois has an exemption and does not impose work requirement, but usually they are imposed on age 19 to 54. And there's also exemption for pregnant women, homeless, the homeless, all veterans regardless of disability, and parents of children under the age of 18. But under the budget bill, the language of the bill says effective immediately, there's now work requirement for persons between the age of 19 to 64, but there's no way they can work that out. So they just make these policies and put it out there, but it's still left to the states to work out the modalities of this policy. So right now, Illinois needs to work with USDA to figure out how they are going to implement this. So we don't know how long it's going to take. We hope it doesn't work out. But that is where things stand right now. But according to the policy, according to the language of the bill, persons between the age of 19 to 64, able-bodied will be required to work or show proof of 80 hours of work, training, or volunteering to keep coverage. There's no more exemption for non-disabled veterans and the homeless persons. So I want us to put into, I want it also to have it at the back of our minds when we talk about non-disabled veterans. I've worked with a lot of them, applying them for Social Security disability, and not all of them have physical disability. Most of them have PTSD, and this is one of the most difficult to prove, this kind of disability. It means most of these people will be kicked off their SNAP benefit because they can't prove that they're amputees or they can't prove any form of physical disability. Also, age of qualifying dependent decreased to 14, and what that means is you have to be taking care of someone below the age of 13 to qualify for SNAP. So if you have a 15-year-old or a 16-year-old, you can qualify for SNAP, right?
The work requirement.
The work requirement.
The work requirement
the work
exemption.
requirement exemption.
Yeah.
And this graphic here shows you the entire 50 states, and Illinois is ranked number 10 out of those that provide SNAP benefits to their citizens. And these make more meaning if you understand the penalty that is going to be placed on states based on the budget bill. So if you make errors, depending on how much error you commit, you will get penalized and you have to pay a certain amount. So I think I have something here that puts those into numbers, and I'd like to read that out for you. Okay, so starting from FY28, states with SNAP payment error above 10%, like Illinois, it's understandable, people make errors. If you're providing benefit to millions of people, there will be errors. And right now, Illinois is part of those that have made up to 10% error in SNAP benefits. So states that make up to 10% errors, like Illinois, must shoulder 15% benefit costs. That is a lot. So if you make more than 10% error in SNAP applications, you would shoulder 15% cost of benefit. What that means is the state will be very careful now. And in the process of verifying and vetting people's applications, they will probably not approve some people's SNAP just because they don't want to make mistakes. Yes?
So you're saying 15% of the overall cost would be a fine or something that has to be paid by the state?
By the state. And I'll put that in dollar figure for you. So in real dollar, that cost translates to $705 million right now, based on everybody approved in Illinois and based on the error percentage. So if they decide to fine Illinois today, Illinois will pay $705 million. They'll be shouldering 15%. $705 million, yes. So, and we can see other states, this whole policy are put in place to just to discourage states that are actually providing benefits to their citizens. So also, as it stands now, USDA through the Thrift Food Association, let me check that to be sure that's what it's called. Okay, so USDA through the Thrifty Food Plan increases the amount of SNAP benefit provided to individuals, and they calculate that based on the federal poverty level. This bill stops that. the increase, if there's ever going to be any increase in SNAP benefits, it has to be passed into law. It can't be an administrative rule anymore. It can't be based on the federal poverty level anymore. They have to debate that on the floor of the Congress and pass it into law. Another thing, Claudia did mention that when we started, that I noticed in the definition of family under families that can apply for SNAP is that they were more specific about the definition of family, and they defined family as a man and a woman and their children. So when they draft policies, it has to be interpreted according to the language of the policy. So does this mean that if a man and a man or a woman and a woman apply as a family, they are not going to get approved? We don't know until the start implementation of this. But this is one of the things you have to keep at the back of your mind. Yes.
So I'm wondering also if that applies to single women or single men. Because if they're defining a family, it's two adults.
Like a single parent. We don't know.
We don't know them.
We don't know,
We don't know how they
that's the
would figure
question.
that out, because this entire bill actually puts a lot of burden on the interpretation of the bill. You know, when they draft policies and pass it into law, there's a lot of job to be done on the administrative side, the implementation of this policy. There's a lot of problem with the implementation of this policy. It's going to put so much burden on the states, and that is why we have to be very careful when we get angry at some point on the state or on DHS, because DHS would have a thick forest to cut through to figure out how they would implement these policies. So yes, that is that on the definition of family under the SNAP, families that would qualify. They did specifically say man and woman and their children. So effective October 1st, 2027, federal reimbursement drops from 50% to 25%. So it's like a co-pay between federal and states for SNAP. So now the federal is withdrawing 25% of what they used to pay. From 50% co-pay of SNAP benefits, they are now going to be co-paying 25%. So that means the state will shoulder 75%. And again, you have to consider what implication that would have on a state like Illinois that is top 10, part of those that provide SNAP benefits. Are we still going to be top 10 by 2027? Effective October 1st, 2028, SNAP overpayment or underpayment error rate, I mentioned that earlier, what it would mean for the states. They'll be paying 50% penalty if they go above 10% error rate, and it goes that way.
Or underpayments.
Or underpayment, yes. So the errors, yes, Patty.
Oh, I'm sorry, I didn't mean to interrupt. I just wanted to say something, and then you had a question here. But an overpayment could be, for example, somebody's had SNAP, and then they get a great job with higher income, they no longer qualify, they try to report their income, but they keep getting a benefit because it takes a while for the state to catch up, and that could be an overpayment. So there's all kinds of things that can count as errors. There's a lady back here with a question.
Yes.
I would like to know if something changed recently in the state of Illinois. My son gets a link card, so he gets SNAP benefits. It's based on income, or lack thereof, and renewals are every August. You have to go in and send in all that paperwork. So the increase in income was $15, and they cut his benefit by $79. I don't get it.
So there are some things happening right now. Some of the options when we talk to people who've had their benefits severely cut, one of them is it actually could just be a mistake. They saw 150 instead of 15. So sometimes those are truly mistakes. Sometimes it's a balance. The formula for SNAP is a balance of income, rental, how much you pay in rent, how many bills you pay, status, disability status, if you're disabled, if you're not disabled, if you're over 60, if you're under 60, if you have dependents in the household. So it's a formula that's not exactly clear, right? So if something does change, it could mean that the rest of the formula has also been dramatically affected. Even though that doesn't feel like a huge difference, it trickles into a bigger difference. So it could be something like that, but that's something that we could double check. We could appeal to at least get a definition
Well,
of the mistake.
I've never had this happen before. He's always gotten a max for, one person, whatever that is,
Right.
you know, and like I said.
We did also see COVID increases. There were increases to SNAP benefits during
Those
COVID,
are gone.
and those are now being phased out as well.
They were gone.
Y'all can always, schedule an appointment with Adani for her to check things out for y'all.
All right, and here, friends.
What did they say about, with use of underpayment too? And should SNAP, like, should it stay the same, or like, same monthly, or does it balance? Because I noticed like someone in my family is like getting SNAP, and it's been like the going up and down, just like a social security.
Yep, sometimes they just make mistakes. Sometimes they are adjusting for things like, because the federal poverty levels change every year, the SNAP benefit limits also change every year. So last year it was, let's say $1,900 a month was the most you could make and still get SNAP benefits, but this year it's more like $2,000 a month to get SNAP benefits. So the federal poverty levels are increasing, and so the rules to how much you get also change as that federal poverty level.
But should it be like, though the balance doesn't kind of be changing every month though? It's like changing
It sounds
every
like that might be a mistake, or they're getting information from if you are working at a job that enters in data to state level agencies, they can sometimes get new data and they will change it if they get information that you're working more or something like that. They will automatically change that. So it could be a sign that it's a mistake. They mistakenly think someone's working, or someone has been reported on their or something has been reported as a change and maybe that was a mistake, or they found something out. So it sounds like whatever that is, we need to check in with them, right? Because I can't diagnose that problem
Sure,
right
I
now.
just wondered if something had recently changed in the state of Illinois that I was not aware of.
Not yet.
Not yet.
Did you want us to save all of our questions till the end?
That would be nice if we could just get through. We still have a little bit more to go, so we want to keep up the pace.
We're almost done.
All right, so this you've added for Medicaid, you've added for Medicare, and it's applicable to SNAP also. Immigrants are not going to be getting any form of social security benefit or federal benefit under the budget bill. There's an exception, and that is just for the Alaska Natives and the, let me see.
Oh, that's what Lisa Murkowski worked out for her state.
Yes,
Yeah.
and I think that's it, the Alaska Natives. So those are the ones that will be getting an exception under this. Yes, that is all about SNAP. I would also want to urge everyone to keep in mind the timeline for when these policies go into effect, because most of them are not going to go into effect immediately, and they would creep up on you. It would start happening maybe after the midterms or after this current administration change hands, and you would think that it's the new administration or the new Congress that is doing all of this. So keep in mind the sunset. Most of this also for the SNAP are permanent. They don't have a sunset date. For the Medicaid, for the Medicare, we have some of them rolling out in 2028 or in 2034, but most of these for SNAP are permanent. One of the programs that is permanently caught in SNAP is the SNAP education that educates people about nutrition and obesity and all of those. They've taken away that program entirely, and the effective date was the 4th of July when this bill was signed. So I'll be handing over to you.
I think y'all are getting the picture. A lot of these rules are set to make it harder for people to keep their benefits. again, when we think about community impact, these things are going to drain other areas of our community. So if you think about the social services organizations in town now and how they're spending their money, cuts to SNAP, cuts to Medicaid, that means now some of those organizations are going to have to redirect their funds that they're doing for after-school programs or to support mothers or to, to do all these other things. They're now going to have to redirect some of this to help people buy food, to help people pay for medical bills, and specifically medications. That's something that we help with, is actually paying for people's medications. And sometimes we're not going to be able to do that because we're going to see drug prices increase. And so I did kind of want to reiterate that these work requirements, this disinformation about work requirements is very difficult to combat. We know that work requirements do not work. Most beneficiaries that are able to work are already working. And actually, according to this graph, this is from the Kaiser Family Health Foundation. 44% of people are working full-time and 20% of folks are working part-time. So again, already we have a majority of folks who are working, and the people who cannot are due to school attendance, disability or illness, or caregiving. So again, people are doing other things, even if that doesn't look like work to the federal government. States have already enacted work requirements like Georgia and Arkansas. What they have seen is a decrease in federal spending, so they get less money into their states from the federal government. We've seen an increase in uninsured folks and loss of benefits, but no increase in employment. So if the goal, again, the stated goal is to get people to work, that does not solve that problem. So this does not work. Work requirements do not work. That is a fact. That's not an idea. That's not an opinion that I have. That is the truth, and we've seen this play out over and over again. What work requirements do is they kick people off of their benefits. This means that states are now going to bear the brunt of implementing these requirements. So not only were these rules added and asked the states to implement, but now the states are going to be penalized for providing benefits and increased error rates, but they're also being given more work to do. And the other side of this, what they're going to do is they're going to squeeze the states so that the states will no longer participate in the federal SNAP program. It is eventually or potentially going to cost more money to run this program than it is what people actually get on their cards or in their benefits. So at some point, the states are going to have to decide, do we take money from other pots of funding to make up for this loss, or do we just separate from the federal SNAP program altogether and try to come up with something on our own? So as we have other budget fights at the state level, just keep that in mind, that the federal government is putting the press on states for these benefit programs. And generally, feel free to jump in whenever, Claudia, community impacts. If you're not part of any of these programs that we've talked about, you're going to see the impact of these bills. We're going to see this with increased illnesses in our workplaces and schools. When people do not have access to health care, they stay sicker. And if you are around sick people, you will also get sick. Unpaid healthcare costs get passed on to other people through health insurance premiums, and we will see an increase in bad medical debt. Unpaid healthcare costs will strain our healthcare systems. Again, our healthcare systems, which are already strained without any of this happening, we are now going to see higher increases in emergency room visits, unpaid visits, and again, who bears the brunt of that? All of us here, whether that's in costs of the hospital's bills themselves, to us, insurance premiums, to other people as well, and then of course, living in a sicker community comes at a great cost to us all. Rural hospitals and clinics will be hit the hardest and may even close due to loss of insurance payments and an increase in unreimbursed care. So again, that pot of money dedicated to rural hospitals, that doesn't mean anything if that hospital has to close because their Medicaid patients, which they rely on, are not able to pay them for the services that they provide. And what you can do, so if you are on any of these programs, please keep your address up to date. These agencies primarily communicate through mail. So if your address is not up to date, you will not get the letter in the mail that says, hey, we need your paperwork. So you can update that online, over the phone, or in person at the Department of Human Services here in Champaign on Anthony Drive. You can also let your elected officials know that you don't want to be in a community with sicker people, and you want your neighbors to have coverage, and you want your neighbors to have food, because when our classrooms are full of hungry kids, that isn't very good. That isn't a good sign for our community when our future neighbors don't have enough to eat. So you can contact your elected officials, share your story and let them know what do these changes mean to you. And you can sign up for CCHCC's email list and we'll keep you updated on what's going on.
I just wanted to add one thing before we get into Q&A. I know that this is depressing. I know that. I mean, we feel this very deeply, and we know it is depressing. But this is where engagement, involvement, learning the facts, and all of that can make a huge difference. And also, this is really why being registered to vote, doing your research on the candidates, and showing up at the ballot box to vote is so important, because it's the people in Congress, in the Senate, presidency, and in the state houses and all of that who make policy decisions that affect all of us. And so I just wanted to mention that. And then lastly, again, as Adani said, sign up for our email list, or we can add you if you check that little box on the sign-in sheet. We can add you because we will be letting you know about opportunities to take action, or when something new is happening, like there's questions about SNAP, has something changed already? Things like that. We'll be sharing out that information as we get it. So being informed is super important. And those of y'all who are here in this room right now, you are way more informed now than most people in this great country of ours. You have more information than most people. Please share it. Please talk to people. Please encourage people to get themselves educated, involved, and so on. And we'll be getting to questions in just a second. I just wanted to share this list of resources. These are credible sources that we use for policy analysis, for understanding things. There's others out there. We use a lot of them, but we just wanted to highlight a few of them. So you can get on their email lists and get documents, go to their websites. They have policy papers that explain things. So I just wanted to share that with y'all. Here we are. Any questions?